Thank you so much, Alice. My daughter compared it to speaking after Professor Sir Michael Marmot as going on after Taylor Swift, Mum. Wonderful. Thank you so much for allowing me to speak to you today a bit about my work, building on community strengths to improving health, an asset-based participatory approach with ethnic minority groups. So I'll speak for about 18-20 minutes, fingers crossed, and then I'll have Serge, Fozia, and Gabi and Moses joining me for some questions and talking about their experiences of taking part in the research. The Marmot principles, I think my research, or our research, really aligns with those three principles aligned here, so 5, 6, and 7. I think they're really important. In case you're wondering why this white middle-aged woman is talking to you about research with ethnic minority groups, a little bit of context. I spent 10 years in the Middle East, and I worked there with Arabic women, mostly Muslim women, around the barriers and facilitators to the uptake of breast cancer screening. But I also worked with Filipino migrant women around the barriers and facilitators to the uptake of cervical cancer screening. Two very, very different groups. As I said, the Arabic women, mostly Muslim, the Filipino migrant women, but strong Christian group. And I saw that actually the barriers and the facilitators to the uptake of cancer screening were very similar. But what also could really help, those enablers were also really quite similar, I thought. And using faith in a positive way, I could see as being a real benefit. So when I came back to the UK around 7 years ago, I started working with a collaborator, Professor K.G. Robb from the University of Glasgow, on working with Muslim women in partnership with Muslim women around developing an intervention to improve the uptake of breast, bowel, and cervical cancer screening. And that's where the IMCAN study led from. That's what I'm talking to you about today. And then a few years ago, the way that I work with the community, I translated to a different type of cancer, prostate cancer, and to a different community, Black African and Caribbean men. And for short, I just say Black men with their permission. So I'm talking to you today about both the IMCAN study and the ProCAM-B study. So what's the actual problem? So we don't have very much data in the UK around religion, but we suspect, based on some data that we have, that the uptake of breast, bowel, and cervical cancer screening among Muslim women is low. And that actually puts them at risk. That puts them at risk of late diagnosis, and that, of course, puts them at risk of worse outcomes. In terms of prostate cancer, now the most commonly diagnosed cancer in the UK, around 15,000 deaths every year, and that's projected to rise. In 2038, we think that that's probably around 17,500 deaths. But the worst thing about this is that actually Black men are twice as likely to develop prostate cancer, as well as die from it. Now, why that is the case, we're still not entirely sure, and there may well be a genetic link, but what we absolutely know is that Black men need to be aware of their elevated risk, and that they probably need to go to their GP and have a discussion around prostate cancer risk and potentially think around a prostate health check. But we also know from some literature in the US that there are barriers to actually engaging with this type of healthcare. And so what we're trying to do in the IMCAN and the ProCAM-B study is to actually explore some of those barriers, but also those facilitators, what can help for both these groups in engaging with this type of healthcare. We wanted to design, in partnership, together an intervention that could raise awareness of cancer screening and of the risks of cancer. We wanted to check whether these interventions actually work, and then we wanted to explore what people's views and experiences were who took part in this type of research. So that's what we did, both in the Northeast as well as in Glasgow. So let's have a quick look at some of those barriers and facilitators that we found. Both communities said that having knowledge of cancer and of cancer screening is incredibly important, but both communities really felt that their communities were lacking this type of knowledge, and so that raising awareness is really, really important. Particularly our Black communities said that, well, the Muslim women also said that having health improvement materials in multiple languages is really, really important, but particularly the Black men said, well, if it's in English, and I speak English because I'm raised in English, that's fine. But however, the language and the words that are being used are not for me. I don't connect with those words. And they actually said, that's white man's language. So they would walk past the bus stop with a big poster around prostate cancer. And they said, well, that's not for me. That doesn't apply to me. So that's really important for us to know. Muslim women also described the worry about modesty and embarrassment and the worry about getting a male healthcare provider. We also heard about some really negative experiences with healthcare, particularly from our Black community. So, for example, they saw GP receptionists very often as gatekeepers, and they felt that they weren't being taken seriously by them. I realize it's difficult to read, so I'll read out to you one of the quotes of our participants. With the receptionist, I think, you know, it's almost though you have to prove to them that you are sick before they want to give you an appointment. There were some really severe experiences of racism. And this is an example of one of our Black men. Some of the questions you go through if you're doing an online assessment is, does the person look blue or purple or whatever color? But none of those colors apply to me, so if you look at me, I'm the same color whether I'm sick or healthy. There was a real lack of trust, and the men really described this lack of trust. Not having a connection with your GP was really important, but also being suspicious of our health improvement efforts. So one of the men said, it doesn't seem to be like there's a logic behind this targeting. All this targeting, like plus prostate cancer is affecting more Black people. I don't understand. But what we also saw is that both our communities really saw faith as being able to be an enabler, working with religious communities, making sure that the messages that we use are aligned with people's values and therefore with their faith, and working with community leaders, religious leaders can all be a real asset. And that's really important, and that's what I really mean with using an asset-based approach, using strengths from within a community. So we work in a participatory approach, and with that I really mean we work in partnership with the community. So both the research teams have got recruitment leads employed by the project, and so these are part-time members from the community. They're not researchers, but they are fully members of the research team. They are there at every research meeting, and they are employed by the project, and they really bridge a gap between the research team and the community. They're really important. We work with a PICE group, a public involvement community engagement group. They are really our advisors at every step of the process, and they are absolutely fundamental in the co-design work that we do and the interventions that we developed with them. That was really handed over to them. What do you think your community needs? The interventions that we developed are also peer-led, and so we trained up some of our members of our PICE group to become peer facilitators, and they led the intervention. And then in our IMCAN study, the work with the Muslim women, we also have an alima, a female religious scholar, and she will join us in a second. And so really making sure that the messages that we use, that they are aligned with the faith. So the interventions that we developed for both of these studies, they are 2-hour workshop. I'm going to show you the example of the ProCAN-B study, so of the prostate cancer, but the IMCAN study is very, very similar in its outline. So we started off with a small group discussion, peer-led, led by the peer facilitators, talking about what makes it difficult to engaging with this type of healthcare? Then we had a black GP talking about what is a prostate, what is prostate cancer, what are the advantages and disadvantages of engaging with a prostate health check. Then we have testimonials from our prostate cancer survivors, also members of the community, on videos. And then we actually have some activities to help people to navigate this healthcare. So what questions can you ask the GP? What can you say to the receptionist if you feel that you're being blocked? Then another real asset from these communities is that they're really collectivist. And so family is a really important part in the community. And so we have videos of 2 women talking about the importance of staying healthy for your family. And then we have videos of religious leaders talking about engaging with this type of healthcare from a religious perspective. And then we have food and time to connect socially, which is also really important. And particularly for the Program B study, the whole workshop was led by the black men. There were black researchers in the background that trying to help with IT or whatever, but the workshop was completely led by them. Our white researchers are not in the room. So this is what we did. We delivered the workshop, and then we delivered it in the Northeast, we delivered it in Glasgow, and then we evaluated the workshop qualitatively. We made a few changes, and then we delivered it again, and then we evaluated it qualitatively again. But now also we gave people questions through surveys before the workshop around their knowledge and their attitudes and their beliefs and practices around prostate health. And then we did the same afterwards, so trying to compare the difference. With the IMCAN study, we have now delivered 16 workshops for 263 women who are not up to date with their cancer screening, 10 online workshops and 6 in-person workshops. So what did we find? Some of the key findings, I can't share everything with you, of course. So what we found is that, of course, as you get to know more about the increased risk of prostate cancer, men did get more concerned about it, and that we would expect that. There was also a significantly improved understanding of the personal risk, but also about that prostate cancer doesn't have to be fatal, and that's also really important. So we saw a significant improvement there. So some of the big changes that we saw, and with big changes I mean highly statistically significant, is that the men really wanted to prioritize those prostate health checks. There was a vast increase in knowledge and also a huge increase in terms of the intention to get checked. For the Muslim women, and this does need to be taken with a pinch of salt, we are still in the IMCAN study and data analysis isn't finished, and we're also still collecting follow-up data. As I started off, I said that we don't actually know very well what the uptake of cancer screening is for Muslim women. And so, but this is giving us an indication, particularly the cervical cancer screening data will be accurate. And so that means that 33% of women were only actually engaging with cancer screening, which is extremely worryingly low. But the good news is that we, again, significantly see the intention to get checked go up after the workshop, and also the knowledge of cancer screening and what it involves is also significantly going up after the workshop. And as I said, so we still have a 6-month and a 12-month follow-up in which we will ask whether women are engaging with cancer screening in that time. A little bit of the qualitative feedback. All participants in both these workshops really, really enjoyed the workshop, and I think that that is something that's been really quite overwhelming and humbling. They found it really informative. The knowledge of cancer and the screening has gone up. Sorry. really gone up. And they really enjoyed those different elements of the workshop. So one of the quotes from our participants is, "For me, I think you covered all ground. You even brought the women to encourage us. You brought religious leaders. We had a GP. I think you covered all grounds." I keep doing this. They really liked having an expert in the room. The GP gave real credibility. But what was also incredibly important for them, and we didn't prompt them for this, but was actually the level of health literacy. So the clarity of the information, the information being brought in normal words that they could understand was incredibly important to them and a real facilitator. So one of the quotes from our participants was, "Talking about a GP, he was calm and he understood every question that was asked, so he was able to respond accordingly. His use of vocabulary, he was not into too much of the ambiguous words. Being an expert, it brought everything to our level as laymen to understand." Did the intervention make sense to participants? Absolutely. They really liked the combination of that medical and that religious aspect. And the way it worked for the women was that the Alima, Serish, really reinforced what the GP had said, and participants found that really powerful. One of them said, "Although you might have that information and awareness, and you might have a GP, but having that Islamic touch, it just kind of pushes it over the edge. Like, yeah, this is important. From an Islamic point of view, we should be getting this done as well." I don't know if you can see this, but this is the picture on the left is GP, on the right is Serish. And the dynamic between these women was absolutely wonderful and worked so well together. It was really powerful. Another thing that was incredibly important is that actually the workshop was delivered by the community for the community. And the black men described this as brother to brother. And they found that really, really powerful. That allowed a safe and free and comfortable space. Those were their words. And that really allowed to build trust. One of the quotations is, "So having someone from our own communities talking about these issues and also having presentations with people from our community makes it relatable. And it helps us to actually understand the enormity of the issue that we are talking about. And therefore, you know, it gets us to the place where we need to act. We need to do something about this." So in conclusion, there are, of course, limitations to these studies. We are building on this work with the IMCAN study. We're still in the middle of it. But I do think it's really important for us in this room to realize that tackling health inequalities, we need to listen to our communities. We really need to build trust. And the only way to do that is to work together, to work in partnership, and to not just involve them, but really also handing over control, handing over what really works for you. Yeah,